So, welcome everyone. It's great to see you. This is the 12th James Reed Memorial Lecture. And about 50 years ago, James Reed, who was a family practitioner in England, published, not online, because there wasn't such a thing, but he published electronically 25 concepts. And those grew into what are known as the Reed Codes. And by the mid-1990s had been widely adopted by general practice in the UK, and were used for billing purposes, quality purposes, and a whole range of data extraction and analytical features had been built in. His ideas and the ideas of others by then had developed concepts with synonyms, preferred terms, a polyhierarchy, and in many ways is part of the strong intellectual and academic basis of SNOMED CT. And so 20 years on, we've gone a long, long way, and we've got much further to go. So it's with, I think, a tremendous sense of excitement that we're here now, and we're going further forward, and we're going to hear from Professor Gong what has happened in China in relation to COVID and the use of SNOMED CT. And to introduce you to Professor Gong, I'm asking Dean Parisi to the stage to talk us through some of that. Dean, please come up.
Thank you, Charles, for that introduction. Hello and good morning. On behalf of the American Medical Association, it's my pleasure to join you. My name is Dean Parisi, and I'm the Director of Emerging Markets at the AMA. This is the third time at this annual event, from Vancouver to Kuala Lumpur to Lisbon this week. I have to say it's difficult to beat the beauty, the landscape, the culture, the great food, and warm hospitality of Portugal. Some of you may be already familiar with the American Medical Association. Our research, insights, and collaboration at home and around the globe have kept us at the forefront of momentous change in medicine for the past 175 years. From writing the first code of medical ethics, to publishing the globally recognized JAMA network, to developing current procedural terminology, for more than 50 years, it remains a backbone for communicating medical procedures across the healthcare ecosystem. The work of the AMA is broad and far-reaching, but it is anchored in three specific areas. First, removing the obstacles that interfere with patient care. Second, by leading the charge to prevent chronic disease and confront public health crises. And third, by driving the future of medicine through innovation and improved physician training and education. The AMA aspires to unleash innovative health solutions that address our chronic global healthcare crises and improve health equity. As my colleague Corey Smith presented yesterday afternoon, it is estimated that access and quality of healthcare delivery only accounts for 20% of what influence the health of a patient. The other 80% is rooted in the patient's socioeconomic conditions, behaviors, and other factors. Addressing these other factors, commonly referred to as social determinants of health, requires collaboration on terminology and data exchange standards to support consistent, evidence-based screening, diagnoses, goal setting, and intervention activities. Our commitment to strengthening the value of healthcare data also extends to the evidence-based CPT code set, a language defined by physicians and adopted by governments and providers around the globe to support healthcare innovation that keeps pace with modern medicine. We called numerous emergency meetings of the CPT editorial panel during the pandemic to develop new vaccine, diagnostic, and antigen tests. It's also worth noting that the 2022 CPT code set has over 260 codes linked to remote care delivery and includes a new taxonomy that provides guidance for classifying various artificial intelligence related services and procedures. Earlier this year, we jointly released enhanced SNOMED CT to CPT map that links SNOMED clinical concepts and CPT codes that support improved resource utilization and patient care. A key to overcoming barriers can be summed up in one common word, translated in nearly all languages: passion. The American Medical Association supports this and the extended SNOMED community each year because everyone here is passionately committed to working together to unlock data-driven solutions that address the global challenges of healthcare. We look forward to sharing our experiences working on these challenges facing physicians, administrators, governments in order to find workable and sustainable solutions. It is now my great pleasure to introduce the James Reed Lecture, Memorial Lecture, Dr. Gong Mengchun. I had the distinct privilege of meeting Dr. Gong in Malaysia a couple of years ago and was immediately struck by his expertise, his kindness, and his humility. He graduated from Peking Union College in 2011 and worked at the University of San Francisco as a visiting scholar. Dr. Gong has worked in the area of applied medical informatics since 2015 and now works as the distinguished professor at the Institute of Health Management, Southern Medical University in Guangzhou. On a personal note, after spending some time, additional time with him this week, I've come to understand that Dr. Gong is the eldest of 3 children, has 2 sisters, enjoys traveling, and plans to visit Morocco, as well as my hometown, Chicago, in the coming weeks. Today, he'll be sharing more on the use of SNOMED CT in the effective surveillance and control of COVID-19 through the Honghu Hybrid System. Please join me in a warm round of applause for Dr. Gong.
Thank you, Dean, for the kind introduction. And also thank you for the generous support from ANA to SNOMED International to support this James Reed Memorial keynote speech. Good morning, everyone here and online. It's such a great pleasure to be standing here. You can call me Mengchun, which means first month in spring in our Chinese lunar calendar. So the 2 sisters, we have summer and winter. So you will see her later in my story of the slides. It has been the first trip outside China since 3 years ago. So I was so excited. I have been in the SNOMED International family for 6 years, and it's always so good to come back home. And here I'd like to extend my great gratitude to SNOMED International management team, everyone, Kelly, especially Kelly, for this fabulous meeting. So today, I'd like to talk with our audience here and also online about data standards and standardization of for public health emergency management and knowledge discovery in a you-know-who disease. So I currently work in the Southern Medical University in China, and I also stand in the board of SNOMED International as a director. So this global challenge has also been a test of our life. It was very closely connected to my experience in SNOMED. It was in the business meeting in Austin of SNOMED International. And then I was flying back to China. And the second day, it's January the 22nd, I flew back to hometown, which is in Inner Mongolia. And after that, 23rd, we have the total block of the city of Wuhan. And the next day is the Lunar New Year. And the next day, 1 week after that, SNOMED International and IC10 released the first set of codes. So you can see how our personal life and international events are intervened together on the perspective of myself. And then my sister, Meng Xia, whose name is Summer, and was sent to Wuhan. She was a local nurse. So Inner Mongolia recruited a medical team to be sent to Wuhan, and she went there. I was kind of envious, and I told her, I want to go too, but I just didn't have the chance. And and then I started to do something myself. We did a Delphi study in China to translate the SNOMED International CT codes. How can we use the Chinese synonyms to raise awareness that probably we should set up some standards to codify the data we're generating. So I'm going to introduce the study later. And then on the February 14th, I was also called to to the province of Hubei. They just called me, can you come? We need some support on the IT build up, and we need some support on the data analytics. I said, why not? I was dreaming to go. So then I was taken to the city of Honghu, which is very close to Wuhan. We are on the border. It's 3 hours of driving from Wuhan. So 48 hours after I arrived in the city, we set up this syndromic surveillance system, and then we initiated CDSS, and then clinical decision support. And then those are the things happening after that. So I was called back to Guangdong, like retreating from the front line on March the 20th. And my sister went back home on April the 1st. So we were safe. My mother was had a very crazy month, that calling both of us every night. But, then the paper was published April the 22nd on JMIR. So Gong is my family name. It means bow for the arrows. So on the right side, that's my family name. So you can see ourselves, the family are intervened with this global test. And so I think everyone has gone through a lot. This is just a good time for us to do some reflection and enjoy the wisdom we can get from looking back. So this is the Delphi study. It was at the beginning of the pandemic, because in China, we wanted to raise awareness for people to use standards to codify the data they were generating. So, but we didn't know what's the right terms, synonyms for the codes that SNOMED released. So we organized over 100 experts, and they submit what's their preferred synonyms. We gave the recommended term and also the synonyms in Chinese. So this is, as far as I know, the first kind of work in this area in our country. And then this was from the paper we just published last month on the Lancet Regional Health. Kind of go through all of these standards. What did we do? Have we done a good job? You can see WHO and SNOMED was working very closely. I mean, we were the first round of standards released to the industry, and then comes to the Chinese version. The Chinese government made some changes of our naming of the disease, and then we were following COVID, and then we released the ICD new codes nationally, and then just as Dean has mentioned, we have LOINC, CPT, and other standards organization working together to generate the whole standard supporting system for the management of COVID-19. So I think this work is very important that we should look back to see how can we do better. Is there any time lag that's caused not necessarily by technology, but by something else? How shall we avoid those kind of problems in the future? So the article has been online now. I will give you the reference later. So today, there are 5 subtopics I would like to cover. So let's go through one by one. So we believe that COVID-19 has been an eminent chance to test the data infrastructure worldwide. So there are several issues we need to kind of think carefully. The coverage of the electronic medical record system and other systems are not necessarily that perfect. I mean, when we were first on the front line, there are some hospitals which are using papers to do prescription, and also they don't have PACS system because you are collecting those imaging data, but they don't have PACS system. So that's some issue that probably we need to figure out how to solve that in the future. And then the interoperability challenges, data sharing mechanism and channels, platforms with sufficient penetrance in the population to support the public health countermeasures, and also the data safety, privacy, and computation resources and expertise. Those are the issues that's very important factors of the data infrastructure. Especially the one interesting thing is the platform with sufficient penetrance. If you want to give people a platform to use to do social distancing and also the education, it should be easy, and it's like in their life that we can use it. So you have WhatsApp, Facebook, and other things in here, and we have WeChat in China, but in many places they don't necessarily have that. So WHO released a score assessment for the data science and data availability and data sharing. So you can see many countries, especially the low and middle income country, has insufficient infrastructure support in the data field. So we believe that building up very well data infrastructure can help you to improve the clinical care service and innovation in the field very fast. This is something we've done in the past 5 years in China. We built up this is just the case for us to illustrate how important the infrastructure is. We built up the National Rare Disease Registry System. Why I use this as the case is that this is the first affiliate license of SNOMED CT in China. So it was given to Peking Union Medical College Hospital to build up this National Rare Disease Registry System. So it was developing very fast. We published some articles to introduce the whole system. You can have a look. So now we have 300 hospitals working together. 200 diseases are registered. Over 60,000 cases have been registered in the past 5 years. And in total, we got 50 million RMB budget from the central government to do this. So we do registry, quality control, and reporting and statistics of the rare diseases. So you can see if we have this kind of national plan and national investment of the data infrastructure, the whole disease area can develop very fast. So we strongly recommend that we reflect and look at our IT and data infrastructure at the national scale so as to improve it in the future. So coming back to rare disease, we have currently the discussion about the international terminology for statistics, which is ICD and NORDO, and also for care and research, which can be SNOMED and HPO. So I think currently the management team has been doing a lot of research on SNOMED for precision medicine, and also we can use it for rare diseases, but it has higher requirements of data infrastructure because in rare disease area, we are incorporating a lot of genomics data. So I think this is the future. We need to do this global alliance to improve the patients in this area. So that's what we should also learn for like any new unknown attack of the any other diseases. So back to the Honghu system. That's my favorite topic. And so we have a lot of limitations for the traditional surveillance system. You can see timeliness, spatial resolution. Those are the challenges, and scalability and connection with other systems. So there has been a lot of researches on this hybrid systems, which means that you cooperate different data channels to support one thing. So that's the methodology we used to build up the Honghu Hybrid System. We used the traditional registry data from the public health system. We also incorporated all of the hospital's EMR taking care of the patients. We also have this syndromic surveillance for the whole community living in the city. And also we have the third lab PCR data incorporated. So you have the very accurate estimation of the cases, and it can support us to do a lot of things like clinical decision support and also follow-ups for the patients at home. So we chose cloud service because at that time, when I was sent to the front line in a very small city with, it's small in China, but probably not small in other countries, 1 million, with the population was 1 million. I can't find any place to buy the hardware for the competition. So it's a small city, they don't have anyone like that. So a lot of things you need to consider about the travel control. No people can go to local places, and you don't have other providers to give you that. And you need to think about the scalability because you don't know where the disease will go. So that's why we chose the cloud service. And we collect the EMR data from 9 hospitals, and we also build up this syndromic surveillance system. And the very important thing I'd like to share is that you need to have a very strong remote support from the engineers other places, like in Beijing, where my team was based, because that will definitely improve the whole progress of the time and also the efficiency to build up the system. So when we were doing the data analytic processing, we believe that this data will be used for the international studies. So we used the common data model and also the vocabulary control under SNOMED CT and LOINC codes, and also we used ICD. So we did some data analytics and visualization. So this was very interesting experience. So you were there, and the local governments, they don't believe in those kind of advanced technologies. This is a disease control. You need to go to the hospital and taking care of patients. How can you just build up a system in such a short time? So I used the manual reporting. Like my team back in Beijing, they do statistics by themselves every 2 hours. Just use that to persuade the local government that we can do it. And after 24 hours of something, my tech team built up the automatic visualization of the data, and then we can show them like real-time analytics. So a lot of things were happening at the front line during those kind of time. So how would you persuade every aspect to support your work? That's something the informatics people knows very well. So I think that's why when we are facing this kind of problem, the power of informatics, and especially who has the whole view perspective to make recommendations, and it's very important to be incorporated. And also we put a lot of attention to the ethics, privacy protection, and also the consent of all of the people who were doing the report, and also giving you their clinical data. So those provided very strong support for the further studies we were involved, because when you are publishing something, you need the consent signed from the patient. So it was the hard work, but we did it. So within 48 hours, we set up the syndromic surveillance system, and then 72 hours data started to come in, and we started to provide some support to the local government. And at the end, the coverage of the system inside the city was over 90%. It was very interesting experiment. How do you make a population in one city to report if they are healthy or not every morning? I mean, during the whole month in the disease. It was kind of not routine. Maybe other cities may not use it, but in China, back then, we just want to see if we can, like, this kind of methodology can be implemented, and if this very detailed collection and analytics of the data can help the team to make the policy decision support. So you can tell it's very thorough questionnaire collected from the residents inside the city. It's a mobile device, so it's very convenient. And we used a lot of support from local government and villages to help us to increase the coverage, and use the trends of symptoms inside the population. You can know how many new people are having the symptoms. It's actually provide you a very strong evidence that the disease control is in effect, because you don't have a surge of the prevalence of symptoms in the population. And use the location data, we can also track and go to the patient's home and provide support. Do you need to go to seek more care? And we will send a team to you. And we also did clinical decision support, trying to migrate the people from the hospitals which didn't have the very strong ICU support to the main hospital, which has the support. But we have 300 cases, and they only have 20 beds. So how did we triaging those patients? These are the clinical decision support tools. And also, this is a new strategy of management. It's an independent channel other than the traditional registry and reporting by the clinicians. This is a channel directly from the residents to the management, the center, and we can send medical service actively to the people who need support. So this is not just a project in field. This is also a research. So it demonstrates some methodologies and can be in a kind of extreme, but you know, if you use it in the future, it provided you a new way to think of the problem. And we also provided a lot of information for migration of the system, how much we used, and what kind of problems I mean, prerequisites if you want to do something like this. So this is the timeline for the cases and who were discharged. So after we arrived in the city, this is medical aid team from Guangdong arrived, and then we built up the team and initiated CDSS, those vertical lines. So 3 important time spots, and then we started to discharge the patients, and you know, this is what happened then. So I was very honored to the work was selected by International Medical Informatics Association as the best paper in public health in 2021. Their evaluation it was selected as the best paper because it documents an impressive achievement and offers a schematic for how other jurisdictions might leverage health informatics systems to manage a pandemic. So, you know, this was, you know, it provided a very thorough analysis of our methodology and the philosophy. So it's not necessarily every city build up this system, but you just want to maybe next wave of this kind of thing happened. How can we use our technologies better? And also it was in the first half of this year, WHO West Pacific have this innovation challenge, and this project was selected as one of the 22 winners. So it's WHO Innovation for Health Impact. So this is really the data-driven public health policymaking, and we want to share it with the world. So then we move to the knowledge discovery part. It's even more interesting. So honestly, as I believe a lot of people know them, I won't spend much time to introduce. So their philosophy is keep your data in a local place, but we share the results. So this is very important for the data sharing in COVID-19 because those data were kind of sensitive in each institute and in each country. So honestly, initiated a very large study-a-thon in 2020. So we collected 4.5 million COVID-19 cases covering 4 countries. So, and then provided a very strong study for the disease characterization and subgroup analysis. So this is the method paper. So in the 4.5 million cases, 886 were hospitalized, and over 100,000 were in intensive case, intensive services. So you can go and see the methodology if you want, but we want to see SNOMED CT played as a key role for the Odyssey vocabulary service. So it's, for example, for China to join the study, a very important infrastructure factor is that SNOMED CT can provide this multi-language linkage and support during an analysis. So there were many thinkings around this. Informatics empowered us to better understand COVID-19. So we published an article very early phase in the disease. It's a Nature Communication to do the deep phenotyping of the disease, to tell you symptoms and medications used in different countries for the disease. And it was a very early paper for the whole world to understand the disease. And then our technology, informatics, enabled us to better understand our patients. So this is the Odyssey obesity study, and you can tell the difference between obesity patients and non-obese patients in outcomes and other things. And this is the pediatric patient. And as far as I know, this is the largest pediatric cohort in the COVID-19 in the early phase, which was very important to tell the pediatricians that what kind of symptoms the kids will have, what kind of outcomes they will have. And also informatics empowered us to better understand ourselves. So this is the study we've done about what how much each medication was used during the whole process and where are they used. So you can see the first medication, which is Uniphobia. It's only used in China. So the blue line was China. So, and this is very interesting thing if you observe, and you can tell how mismatched the practice was during the first phase of the disease in this kind of modern Western medicine has developed so many years. And why did we do such a job like no one knows what's the right thing to do, but we are just following our experience. And so what happened on the battlefield? What should we do for the next wave? How can we get better prepared? So this is the BMJ paper we published about those medications usage in different countries. You can see each country has a very different method or guidelines to use the medication. Even in the same country, in the different institutes, for example, in the USA, it's very different. So this is cross-sectional in different countries. And then look at the timeline. This is a very interesting figure. This is a hydrochloroquine usage based on the time. You know why that surge happened? Because one president announced in the world that hydrochloroquine will help the patients. And then a lot of people, a lot of other work were done and say it's probably not effective and can brought harm, then it's going down. So you can see how do we make better decisions? How can we get the evidence faster? How do we navigate our clinical practice in the pandemic? So these are all informatics brought to us, and actually SNOMED CT stand in the core of this whole process of the study. So you can see we published a lot of articles like asthma patients, autoimmune patients, cancer patients with COVID-19, and also pregnancy, obesity. So it's SNOMED CT plus Odyssey and other international collaboration system help us to understand our patients much better in a much faster way. So this is about the knowledge discovery. So I believe coming back to the IT infrastructure point, the paper we published on the Lancet Regional Health was looking back at the data standards and data standardization. We believe that's the shortest plank of the bucket for the whole effort, because the major challenges are inconsistency in data standards and standardization, lack of usability for the layperson, difficulty of deployment in resource-poor settings, and also the potential ethics and legal barriers. Those are the country problem we have for the machine learning based or informatics empowered solutions migration, even though they are developed in many places, but it's very difficult to migrate them because we're not having the sufficient infrastructure to support them. We did some work, which was published on eBiomedicine. We developed a very simple model to predict the severe cases. And here is the lessons we learned from this study. You need to find factors from routine clinical care, evaluate it very frequently, very low cost. It can be supported by the electronic system, and it should be measurable and should be objective and should be existing standards to support them. So those are the models that, successful models that can be used widely, but for the others without these factors, it will be very difficult for them to migrate and do the decision support. So we are highly recommending that we get more prepared for data sharing by improving our data standardization around the world. So, we need to make the data we collected in machine readable form and observe the necessary privacy standards and try to use the wide coverage, use the standards with wide coverage. So this is very important when no clinical data is informing what's happening on the field, and the public will raise the expectation that probably we can generate something like that for them. So last but not least, I'd like to point about the future. I've been mentioning this a lot, in a business meeting because they are having this argue on the new standards. But I think the medicine is evolving to the machine learning based knowledge discovery in the multi-omics integration databases. This was a paper published in 2013. It was very early, but it's actually directing the development of medical informatics in the past 10 years. That you have the phenotype, you have the genotype, and for the patient, for one patient, incorporate their genome and phenome, and then you have a large volume, large group of people, and then you do the knowledge discovery based on this database. So you have phenotype, phenome, and then we do phenomics, the study of phenome. So it's an evolving academic research area, and we have the clinical phenotype, clinical phenome, and clinical phenome in different human races, and then integrate of human phenome with other omics. This is the future, I believe. Trust me, like in 5 years, when we have this discussion again, you will see the huge and fast development in each country in this area. So we also are talking about deep phenotyping. So how deep is enough? We have the behavioral, morphological, physiological, cellular, proteomic, genomic, transcriptomic, microbiomics. So those are what the data is, where the data is, and those are what we need standards for. So we need standards in human phenomes for semantic data elements, capturing, measurement, and also quality control and other things. So I like this picture that SNOMED CT generated. I believe it's 5 years ago. In my first SNOMED business meeting, our precision medicine team joined this. So we are the hub of standards in life sciences, and life sciences moving towards to a multi-omics integrated knowledge discovery era. So SNOMED CT will definitely play a stronger role in the future. So last but not least, I'd like to extend my gratitude to Professor Zhu Hong, Professor Liu Li. Those are the two persons standing in the picture in my on the right. So this picture was taken when we were going out of Hubei province. So we were in a team to build up the system, did the data analytics, and these are the very important research collaborator of me. And I also like to extend my gratitude to Dr. Shi Wenzhao, which is the CEO of DHC Technologies, which has been supporting us during the whole process. And also all the patients and residents in the Honghu city who were involved in our study. And also my family, who has been supporting me very strongly. I mean, my mother, she was kind of concerned when I was leaving, but she still supported, say, this is the right thing to do, and you have to go there. So thank you very much. Thank you again for SNOMED International to give me this chance to talk about this. Thank you.
Well, thanks for a great talk, Mengchun. I'm looking at the audience, so this is your time to have done a bit of thinking and to push questions out to me. But I'd quite like to start with a question really about the humans in Hongzhou. Why did 700,000 people answer your questionnaire?
I think we have a philosophy there. Like we call it the Honghu strategy. So for any kind of things like that happen, you need several stakeholders work together. So the first, we call it guided by the experts. So at that time, we have a lot of medical team from other provinces like Guangdong, Hainan. So these are not the local experts. So these are the national hospitals sending large teams. Like my Guangdong team has over almost 100 doctors and nurses. So they were there sent by the central government. So you need to build up very high confidence of the local residents to trust that we can win the battle. And then that's the first point. The second is the coordination by the local government. That's very important. We were there to help them. but they were the people who are doing the job, in a village and for the family. So you need to talk to them very closely and share your thoughts. And that's the second. The third is we call it we need the IT support and very advanced technologies to support, because you don't give them too much burden to do. Like every morning they just do a questionnaire. It's very quick, like 2 minutes or something. So that's not that that's not no money, but that's not that difficult. So the fourth, I would say the most important part is you need to have the very active involvement with them, with the residents, like on the media, to do the broadcasting and try to go to the communities and talk to them. I did that a lot with the Professor Zhu, who was in the picture. He was the team leader. So he took us to visit the families, visit the communities, and so that's what we did. So I think that's probably the 4 success factors of that. We actually put that in the paper and published in Chinese and on the Chinese medical journal. I didn't share it today, but that's our philosophy.
Great, thank you very much. There's a question there. I think microphone's coming to you.
Hi, I was wondering, thank you also for your presentation.
Thank you.
And sharing your insights with us. I was wondering, because of the limited time I can imagine the system was not very user friendly. I saw you elaborating on that in your article. I was wondering can you elaborate on the lessons learned on that, how you would do that in future wise, and what can you reflect on the role of clinicians in that?
Sorry, do you mean by how do you use SNOMED CT in that period of time, right? In the process, right?
Now, how you make the changes you made in the systems to get your data, how can you make them more user-friendly so that you actually get the data you actually need, and the role role of physicians in that?
Okay, thank you. So in the system, there are 2 parts. One part is for the residents. So for that part, you have to make it very high user-friendly, because they're not going to use it. So the questionnaire were designed by a team of clinicians and public health experts, and also some people from local hospitals, and we work together. So it's not a long questionnaire. It's short, and on the user interface, it's just tick, and it's easy. So, but for the other part, like the data analytics part, it's only for the researchers and for the policymakers. So we use the very high burden of people in other cities. Like back in Beijing, I have a 20-people team to support me to process the data, do the analytics, even do the visualization by manual. So every 2 hours, they generate a new set of slides. Just I can use it to persuade all of the people that the technology was working. At the beginning, for 24 hours, I used that. So that's how did we do that? For the clinicians, we involved them very early, because I was a clinician myself, and we have a team of doctors sent by the hospital to support the data work from Guangdong, from the hospital in Guangzhou. So and we also have the local hospital doctors working with us. So they provided very important guidelines. I mean, for the clinical decision support system build up, for the triaging of the patients, like every morning when we have the list of risk scores, our doctors will go to the hospital and find those high-risk patients and ask them to be transferred to the hospital with the ICU. So that's why when the system was initiated, no patients died, because you can find them very early, because their lab tests and other things are telling you they are more sick, and you just need to get them to the hospital with the ICU services earlier, so that you can prevent further poor outcomes of them. Yeah. Thank you.
There's another question in the back, Mark Jerkovich. Mark's a dentist, by the way. So.
Oh.
But this is not a dental question. So, one of the studies you cited, you were showing that you obtained data from, or worked with Odyssey, worked with IQVIA, worked with Optum, et cetera, et cetera. And I recognize that they use a common data model, or at least a similar data model. Well, this was evolving so rapidly, and there was so much new information coming in that the consistency from the clinicians, et cetera, I would think would have been difficult. Did you do some validity checks, or did you just get enough data that you had a high level of confidence after the fact?
Thank you. This is a very important question. Yes, technology is developing fast, not just that, but also the data. I mean, it's from different sources, and the quality, it's always an issue for that. So you can see the studies I'm sharing just now, I was sharing just now, most of them are like analytics of what was happening. It's not like prediction or conclusion with a very high level. It's basically describing how are they treated, what are the symptoms, what are the outcomes. So at that kind of time, this is very important because we don't know much thing about the disease, the characters of the disease, or the characters of our patients. But after that, I can see Odyssey use many other data sources to do higher level studies. Like for the paper they published on Lancet in 2019, it's a very strong real-world evidence study. So for that part, they need more data, I believe. For example, it was selected from 250 million to generate a population of 5 million, study population of 5 million. So it's 1 to 500 or something like that. So I believe in the future, when more and more databases are following these open science standards, Odyssey is not necessarily only one, they have some new ones. We can have larger population to study population to generate real world evidence, but still it should be step by step. The first step would always be like for you to help you to understand what's happening on the field. For example, one study we just finished in China based on our national chronic kidney disease database. We have 10 million cases in the database. We analyzed the basic treatment pathways of our chronic kidney disease patients. So this is an evolving area, and I believe our standards, our methodology of SNOMED will definitely help them to grow stronger in the future to generate evidence for medical area. Yes.
I have a question.
Thanks, Hongchun.
Is it on?
There's a question at the back.
Can you hear me? Okay. Thank you very much for sharing your experiences. I would be interested in knowing if/when a thing like this would happen again. With your experience now, what would you do differently?
Oh, thank you. Thank you. This is a very good question. The first point, I would go there earlier, probably. At that time, I didn't get the chance, but I was kind of lucky to have some connections in the hospital, and they know I can do something on informatics, and they called me, and I was not even a formal member of the team. I was kind of a volunteer to the team. Something differently, I think first point is, it's actually the theme of this topic. I mean, we need to provide the doctors and the public health experts with strong informatics tools. So they were there, firstly, a lot of them use the medical paperized records, and a lot of us were still relying on the traditional registry systems to predict the size of the patients. And so first part, we should initiate the informatics tools. We are in the era of new tools, and so it's just the informatics people need to work with them stronger, in a stronger collaboration and earlier in the phase, so that we can provide them with a perspective from the whole system and a longer strategic view, so as to help them to increase the efficiency. So a second thing I think would be different was that we should probably initiate the data analytics with in the international scope earlier, because and share those knowledge in a faster way. I believe the publication industry has done a really good job. They changed their process and philosophy in the early phase, but I think still for the clinicians, they still need more more knowledge about the disease in a faster way and in a more like decision support thing that maybe that can help them to reduce the burden and increase the efficiency to take care of patients. Actually, I think we did quite a good job. So, so these are something that I think should be done differently. And yeah, thank you.
Thanks. My controllers, yes, now they're going to allow one more question. In fact, two more questions. No,
yeah, I appreciate it. Thank you very much, Dr. or Professor Gong. Really, this is amazing. Now, after listening to all the questions and answers, I remember when I moved to Sweden, when I moved into my student apartment, I had to go to IKEA to buy what we call a startup kit, where you have everything in a compact box to start off with, the essentials. So would you say that with all these experiences that you have collected in the past, this very recent years, with all the immerse, it's not just the quantity, but it's also the depth of the experiences, would you have a kind of a startup kit? There are many nations that are kind of in need of this, and they do not have the resources. Either they don't have 50 million RMB and so on. What would you say? Would you?
Yes,
would that be available?
Yeah.
Yes.
Yes, that's a great question, and thank you for that. I think in the past several days of conference, I've heard some projects like international EMR for the low-income country and things. And I also believe that United Nations and WHO are also doing some projects. I was involved in a global health informatics work group of IMIA, American Medical Informatics Association. We had something projects like that too. So for the startup kit, that's a very good point to think about this question. How can we collect all of the resources together and help them? But I think currently the technology migration and the accessibility to the cloud service, I mean, it can be provided by other organizations and to one region or one country. So it's just the global alliance need to work together to do this and provide some low costs, I mean, easy to access platforms based on the internet or social media to help at least collect a part of the data. So for the integration of the clinical data in different hospitals to make them together, that's cost resources consuming. So it's probably the next phase. But for the first phase, I think at least you can see the score evaluation by WHO. A lot of countries are in need of this very basic level infrastructure support. So yeah, we should rely on international support and global alliance. And the solution should be like more on cloud-based and internet, so as to help people. And SNOMED has also done a lot of work in educating and supporting low-income countries. And I believe that will also help a lot. Yeah.
Thank you so much. Fantastic talk, fantastic questions.
Thank you.
So congratulations to all of you. And then I'd like to call to the table Ponciano Vieira just to round up the morning session. And thank you so much for coming to us and sharing your thoughts about our conference. Thank you very much.
Well, good morning to all of you. I hope that you are enjoying your SNOMED Expo here in Lisbon. And I hope that everything came up to your expectations. For us, it's a pleasure having you all here especially after these 3 years that we were well affected by this pandemic, and it changed our lives. Well, and here we are today, and hoping that we could share with you all of our experience, and well, thanking you and your experts, especially to SNOMED CT. And I would like to thank Don Sweetie, and particularly to Kelly Carew and her team. She was my focal point during these last months, and everything from our point of view was very well organized, and we hope that we could correspond to that expectation. Switching for a technical point of view to a policy-making point of view, for us, semantics and language is, since the beginning of time, as we see it as a nation, a demand, not an option. We changed the world in the 16th century. We changed the world map. We live in a European community integrated. We are building a European health data space. We are in the front line of that project. We are supporting the principal ethical principles within digital health, and we live in a Portuguese spoken language community. So in this globalized world, we are exposed, we are all exposed, our health profile are exposed to world health profile. So semantics and languages are not anymore an option. They are a demand for providing healthcare solutions and healthcare in general to all the people in the world. Therefore, we would like to thank you again for being here, organizing this event, for raising awareness about this issue. And we hope that we could share and we could contribute for that goal in our proportion and with all of our skills. Last but not the least, I would like to thank our SPMS team. I would like to especially thank to Sandra Cardoso and her team, and Filipe Mialha and their team. Hope that they could be of good use to all of you. See you next time. It was a pleasure having you.